Good afternoon. I'm so grateful to be here today. I wish this disease would take me before I had nothing left to leave for my family. This is one of the statements that was said to be with one of my patients during my qualitative data analysis. This is a patient who had been referred from Bundibujo. Bundibujo is an area in the west of Uganda. He had been referred by his member of parliament to come to our unit, and I happened to interview him, and this is one of the statements that he said to me. Just to show you, this is a slide that was presented in one of the World Kidney Congress conferences, looking at the prevalence of chronic kidney disease among its patients. This was a study that had studied patients all the way from 2000 to 2013, so it's fairly old. But this is Medicare patients, and these are patients who are supposed to ideally be getting good care. But you see the progress of chronic kidney disease actually increasing every year, and this number continues to go up every year. Kidney disease is like an iceberg, a proverbial iceberg that hit the Titanic. You don't really know what is happening. There's a lot going on underneath before things begin to show up. In Uganda, it's the 13th leading cause of death, and there's only 2 places in Uganda where you can get treatment, with very few nephrologists able to offer care for Ugandans. So my study is quality of life for patients who have end-stage kidney disease. I'm looking at Mulago National Referral Hospital, which is the hugest, biggest hemodialysis center for people in Uganda, and I am a PhD student. So my study is actually a combination of both palliative care and kidney disease. Palliative care has been defined as an approach that looks at the quality of life of patients and their families, not just the patients, and it aims at relieving suffering. And the goal is to make sure that you improve the quality of life for patients. Now, this definition is changing every year. We're not just looking at patients who have life-threatening illnesses, but looking at patients who have chronic illnesses. So that means diabetes, hypertension, chronic kidney disease inclusive. And we actually have a new paradigm for looking at palliative care approaches. The burden of kidney disease is quite significant in Uganda. Like I said, it's an iceberg. You don't really know what is happening. There's a lot happening underneath. Most patients who do present at the end of the road. This unpublished data from MRC actually shows us what is happening, because 2.2% of patients, normal controls, so people who are supposed to be normal, actually had an eGFR of less than 60. So a normal person usually has eGFR of over 90. So when you begin to go below 60, then you're described as chronic kidney disease. And for end stage, you're going less than 15. That's my main study population. The main causes are diabetes and hypertension is actually quite prevalent. So looking at palliative care, really, the old concept was that once someone is defined as having a terminal illness, then palliative care begins. But the new paradigm is that you begin palliative care once the diagnosis is started, and then you increase the amount or the degree of support that you're giving to the patient until eventually death occurs. But that's not just the end. We continue to offer bereavement care as well for the people who are left behind. So kidney disease, really, once a patient has kidney disease, there is 3 options of care. You can either get a transplant, you can get hemodialysis, or you can get supportive care. In Uganda, there's no place available for transplant. It has to be donated by your family member, and it costs quite a lot of money, so over 100 million. And that's just a start. For hemodialysis, like I said, there's only 2 places where you can get it. You have to do it 3 times weekly, so you have to move back and forth. And it costs 2 million to start, and there's a big cost after that. For supportive care, it's essentially holistic care, and it aims at improving quality of life. Now, quality of life has been defined as a person's perception of what they think, what their position of life is in context to their culture and their value systems. I came across what we call the Calman's gap, which is essentially a quality of life deficit. So a person's expectations usually in comparison to what the reality is what determines at any given moment what their quality of life is. For example, if you expect that you're going to make a lot of money today and buy a very expensive car, and in reality you're only going to go home on a bicycle or a boda, your quality of life is quite significantly impaired. So what it means is that if you're providing care for all of your patients, as long as they are chronic illness patients, it's very important to be able to tell them what the reality is so that you're actually helping them to improve their quality of life. So my study really was looking at patients who are on hemodialysis versus those who are on conservative management and following them up over a 12-month period. And in doing that, I have both a qualitative and a quantitative component, looking at the potential predictors and looking at the survival of their patient, of the survival of these patients over a 12-month period. So it's the different topics I'm looking at. The first is the comparison of what the quality of life scores are for these two different groups, looking at the factors that are involved, looking at the 12-month survival and mortality, and then also looking at the lived experience. So my progress so far in the quantitative arm, I've been able to get all the approvals involved and full university registration. I've got 156 out of 37. That's my overall sample size questionnaire field. The 3-month review has just started right now. And the 33 patients recruited in the first month, 12 have died, so mortality is quite significant. I expect that it will probably be the same picture throughout the month. 10 have been lost to follow up because of not having good phone numbers to call them back, and also their relatives not having phones, but we're working on making sure we have multiple phone numbers and multiple contacts for patients going forward, and 11 were reviewed. So just briefly looking at what our numbers are looking like. Majority of our patients, 84% were hemodialysis versus conservative management. Most of our patients are aged between 50 and 70. We found that many of our patients, almost half, have 3 to 12 dependents, so that's going to be a problem going forward. And we also found that most of our patients have do not have fistulas. Fistulas is the access for dialysis. And looking at the qualitative arm, we found that the emerging things include financial constraints, which we thought would be a problem. So just maybe reading one of the quotes, the patient says, the doctor told me that every day I have to have an injection. Injection costs 130. Has to get the injection on his arm. This is the father talking about his son who was getting the treatment. It costs 60,000, then he has to buy another one, which is 19,000, and then the total is almost 100,000. And then he says, now a farmer like me, honestly, how can I get this money? So this is the picture that we're getting for most of the patients as regards the financial point of view. And then also we found that there's a huge significant disease burden because the kidneys do a lot of work for you as a person. They get rid of most of your toxins, so you have to be on treatment to get rid of toxins. They get rid of your fluid, you have to be on treatment for fluid. They get rid of, they help you make blood, so you have to be on medicine for blood. So the amount of drugs patients are taking are quite significant. One of the patients said to me, the husband who was buying the drugs thought that she was a con artist, because the husband was like, how can you be on this amount of drugs? This is not normal for one human being. So the patients are finding it very difficult to cope. So that is my preliminary analysis. I'll have more going forward. So as far as public engagement is concerned, we have had been to schools to do some public engagement, but I've also been part of the Uganda Kidney Foundation, which is an advocacy group to try and improve care for patients with kidney disease. We have been to Parliament. We have tried to urge members of Parliament. The picture we took with the Speaker of Parliament after we talked to her, and she was very positive about kidney disease. The interesting thing is that most people don't realize that it's a big problem because they don't talk among themselves and they don't realize that the person sitting next to them knows somebody who actually did have kidney disease, so it's actually a huge problem. And through this mobilization, we've been able to source for more funds. Hopefully the new budget will have more funds. I'm actually looking forward to see what they will say next week in the new budget. And then, as far as grants are involved, I was invited to speak at the World Congress on Nephrology in 2020 next year. I'm finding out that people are interested in palliative care and kidney disease because it's a huge missed opportunity for many patients. And I was given a grant to do that. I applied for a L'Oreal UNESCO Women for Science grant, which I'm waiting to hear for in July. I'm supervising 3 master's students. One in microbiology is looking at the organisms within the dialysis unit. One in internal medicine is looking at patients in Masaka Hospital who have diabetes and trying to see what the prevalence of kidney disease is, which I think is a good topic. And then one for palliative care, a nurse who's training to be a specialist. I'd like to thank all of the Thrive and all the partners. Thank you so much for this opportunity. I'm very honored.